I think it's a time, okay, so it's going to be recorded. I think it's about the time that we should start the program. So welcome to the first session of How I Care online short course program. First of all, I'm so glad that we're having all of you virtually here with us for this program. I am Arvind Mirshahi, a student of medical surgical nursing at Tehran University of Medical Sciences. I want to inform you that we have registered more than 190 participants from 10 different countries around the world. So I have to say to some of you good morning, to some of you good evening, and to some of you maybe good night. Before starting the program, I want to explain a little bit more about How I Care. How I Care is a free online short course program planned by the Deputy of International Affairs of Nursing and Midwifery School of Tehran University of Medical Sciences, aiming to bring together the nursing and midwifery scientific experts from all around the world to share their knowledge and experience and thoughts. And the program will focus on the latest updates and the professional and evidence-based care in the field of nursing and midwifery. And it is expected that this will allow the audience to reinforce the knowledge required to deliver comprehensive and professional care. Of course, this was realized with the help from the Appraised Race team, Vice Team for Educational Affairs of International Campus, and of course, the support of Director of International Human Capacity Development of Tehran University of Medical Sciences. Now, briefly, I want to introduce our speakers and moderator. Our speaker for this program with the topic of integrating early palliative care in the chronic illness journey translation across cultures are Professor Marie Bakitas and Dr. Rachel Wells from University of Alabama at Birmingham, United States of America. Of course, our moderator, Dr. R.P. Manoukian, will introduce them in detail. And our moderator, as I mentioned, Dr. R.P. Manoukian, she's an associate professor, Department of Medical Surgical Nursing, School of Nursing and Midwifery, Tehran University of Medical Sciences. I hope you find this webinar informative and helpful. Here, I pass the microphone to Dr. Manoukian. Thank you. Dr. Manoukian, please.
Thank you, Arvind. Hi, everyone. I'm R.P. Manoukian. I'm so honored to welcome you to the first course of How I Care Medical Surgical Nursing Series entitled Integrating Early Palliative Care in the Chronic Illness Journey, Translation Across Cultures. This program, organized by International Deputy Deputy of International Affairs of Nursing at Midwifery School in association with Appraised Race team of Tehran University of Medical Sciences. First of all, I'd like to express my special gratitude to our invited speakers. I'd like to introduce them shortly. Our first speaker, Professor Marie Bakitas, is Associate Dean for Research and Scholarship, co-director of Center for Palliative Care at Alabama University at Birmingham. Indeed, Professor Bakitas is an international expert and scientist in the field of palliative care, whose research and papers led to tremendous and significant changes in practice. And really, it's a great pleasure for us to have her with us. Thank you, dear Marie. Our second lecturer is Dr. Rachel Wells. She's currently a postdoctoral fellow at nursing school at Alabama University. Her research interests are focused on developing early and multi-component palliative care interventions to under-resourced people with advanced illness, especially advanced heart failure and their family caregivers. Million of thanks for her contribution in this program. Let me introduce my colleagues at Medical Surgical Department who supported us to organize and to hold this program. First of all, we are honored to have Professor Ali Reza Nikbakht Nasrabadi with us, the Dean of Nursing at Midwifery School of Tehran University of Medical Sciences, my dear Professor, Dr. Shahrzad Ghiyasfandian, the head of Medical Surgical Nursing Department, my other colleague, Dr. Shahsavari, Vice Dean for Educational Affairs from Medical Surgical Department, and my dear colleague, Dr. Zakari Muqaddam, the Associate Professor of Medical Surgical Department. Million of thanks to all colleagues for their participation and their support. Well, since our first program is about palliative care, I think it is worthy to start this program by the famous quote of Cicely Saunders, the founder of modern hospice movement. She says, you matter because you are, and you matter to the last moment of your life. We will do everything to help you, not to die peacefully, but also to live until you die. Obviously, when we are talking about living the life, we should take into account that there is an important component called culture. Exactly, culture shapes the way we are looking to the world, we are looking to the life, shapes the way we seek meaning, shapes the way we interpret different situations, and even shapes our behavior of health. And today, our invited lecturers, invited speakers are going to share their valuable knowledge and experience in this regard. I hope that this program would be a good opportunity for all of us to learn from each other and to share our experiences. Actually, you can type your comments, you can type your opinions and experiences in the chat box to share with the other audiences. And now I'd like to invite our esteemed lecturers to start their presentation. Dear Marie, dear Rachel, we are all ears to listen your interesting presentation. Thank you very much.
And thank you, Professor Manoukian and Arvin. We have so enjoyed knowing you and working together with you in your master's thesis, as well as all of the work that you're doing around palliative care in Iran. It has been a great pleasure and a great honor, and we are so happy to be with you today, this morning, this evening, this afternoon, whatever time it is for all of you there. This first slide shows our very vibrant campus at the University of Alabama at Birmingham. Though I have to say that where Rachel and I practice and what the work we do looks very different, and we're going to be sharing some of that with you. This is the, as I said, we are very grateful that our hosts have given us this opportunity to present on this very important topic. We are sharing some of our funding disclosures and acknowledgements of the support that we've received over the years to do this work. But I'd like to begin with great humility. As we prepared this presentation, it became clear that we have much more in common than we have differences when it comes to trying to bring palliative care to everyone, everywhere. As symbolized on this slide by the logo and the tagline of the Worldwide Hospice and Palliative Care Alliance, each November, we celebrate World Hospice and Palliative Care Day. And that effort reminds us that across the world, our mission is to join hands to reduce suffering. And to do this, we must leave no one behind to ensure equity and access to palliative care. I say this message is both simple and profound. We must approach this work with respect for all and a desire to reduce suffering in the people that we care for. Our cultures may have different ways to go about it, but our hearts, bodies, and souls are committed to this mission. We suspect that some of our ideas that we put forth today may not apply in the same way in your culture. However, we look forward to continuing to work together to find the best ways to reduce suffering and improve quality of life of those in our care and our community. Today, Rachel and I have organized the presentation into 3 sections. First, we're going to talk a little bit about common definitions of palliative and supportive care. And although it's 2 countries, it's really one perspective. Second, we're going to share the about Enable, which is an evidence-based intervention that we've been developing over the past 2 decades, and how this intervention has made a difference in the US and other cultures. And really, the main focus is going to be on the importance of whatever it is that we do in palliative care requires cultural adaptation. So this journey started actually in the 1990s when the World Health Organization proposed a new radical way to look at the care of persons who were newly diagnosed with cancer. They proposed that the dichotomous model shown on the left was how current care was being provided. And they suggested that when cancer progressed, it was too late to start to bring pain and palliative care relief. Rather, they suggested that these elements of palliative care begin as soon as the disease was diagnosed and continued to increase as other options for curative or therapeutic care were reduced. This slide shows an updated version of the World Health Organization model, which I just showed you, which continues to guide the development of palliative care services across the US. And the World Health Organization has declared palliative care to be a human right. The important points about the definition of palliative care are shown in red, highlighted in red, that it's for any age or diagnosis for people and their families, about dealing with the symptoms, pain, and stress of serious illness, provided by a team of doctors, nurses, and other specialists, and providing that extra layer of support with the other clinicians, and provided along with or concurrent with disease-directed therapies. I was so excited to find this image, same image, on your Iranian Cancer Control Center website, where all of the principles that I just showed you in the US version are mimicked here in your same model. So again, we are two countries, but same philosophy of care. Many people think, what is the difference between hospice and palliative care? And I use this very simple graphic to try to show that difference. Palliative or supportive care, which were two terms that we use interchangeably in the US, is really the big umbrella of care. And hospice is a type of palliative care that is provided in very specific ways and much closer to the end of life. Similarly, comfort care is that care that is usually provided within the days or hours of the end of life. But it's all palliative and supportive care. It's just provided at different times with different parameters when people are closer to the end of life. And then symptom management, of course, is a field that has some overlap with palliative supportive care and hospice, but also applies to many other conditions. Similarly, here on your Iranian Cancer Control Center website repeats the same message about the relationship between supportive palliative care and curative care, indicating that although therapeutic care is provided solely for the promotion of life expectancy, the main purpose of supportive and palliative care is to improve quality of life and quality of death of the patient and also to the patient's family. And again, says the same message that it is provided from the time of diagnosis, parallel to treatment, and beyond the completion or cessation of treatment. So I just wanted to further emphasize that we have the same understanding and beliefs about palliative and supportive care in our countries. Also, the targets of these populations the three main targets of these populations to receive palliative and supportive care include patients with all chronic diseases, although as the World Health Organization definition, and we have shared, that it often began in cancer patients, but is certainly appropriate for patients with other chronic illnesses that cause quality of life issues. Similarly, for caregivers and the families of patients, and supporting of the relatives is key, both from a psychological and spiritual standpoint, as well as social and economic dimensions. And again, not only for cancer, but for all patients with all chronic illnesses. And lastly, and becoming much more important, especially with the pandemic that we've all been facing, is the staff who contact patients directly, because burnout is a major concern. And so we must also be providing care for each other as we provide care to others. In Iran, you see here that the status of supportive care in different countries as has been followed for many years by the World Hospice and Palliative Care Association. And what they've shown is that different countries have different levels of provision. When they first started collecting data, Iran and other countries across the world were separated into these four categories, with category 4 being the most advanced. Iran has risen to category 3, and keep in mind though that these data are now 5 years old, and so what is current may even be much more improved than what is shown here in terms of Iran and also in other countries. This slide shows the number of persons per 1 million population receiving care, in Iran, receiving palliative care. In Iran, that would be about 150 to 550 per million compared to the US, where there's 3,000 to 42,000 per million. Now, there's multiple reasons for this. In the US, the workforce and resources are much larger and more mature in the area of palliative care. However, as you'll see, where Rachel and I live and practice in the US is probably much more like where you are there in Iran. In the US, that little star there shows where we are located in the US. And it's interesting because the way the data are presented here, it makes it look like the United States is a sort of a monolith, or there's the same advanced level of palliative care available. But let me show you some data from the United States. This is a survey that was done in 2019 of hospital palliative care. And each state in the United States received a grade from A being the best, or having 80% or more people having access to palliative care, and D being the worst. There used to be an F failing grade, and Alabama was right there. We've progressed up to a D. So you can see here in orange, the state of Alabama and our neighboring state, Mississippi, have the lowest access to palliative care in the United States. Only 20 to 40% of our hospitals have provide access to palliative care for their patients. And so, as I'm stressing, we have the same issues and the same problems that occur nationally, even though when you put all the data together, it makes the US look like we're doing quite well. Similar to what you experience in Iran, the general public has a very limited awareness of palliative care. I would say that in the US, there's also a similar lack of awareness of all that palliative care can offer to our patients on the part of healthcare professionals. So you could see here a public opinion poll asked citizens in the United States what they knew, if they were knowledgeable, if at all, about palliative care. And you could see 70% of the people were not at all knowledgeable, 14% were somewhat knowledgeable, and only 3%, or probably 3 to 8% were knowledgeable or very knowledgeable. So you see that it's one of our imperatives that we have to continue to educate ourselves, our colleagues, our patients and families about palliative care. And that's why I'm so excited that we have this opportunity to share together today. I'd now like to turn the program over to Dr. Rachel Wells, and she's going to describe one model of palliative care that we call ENABLE, which is consistent with the philosophy promoted by the World Health Organization. ENABLE has been shown to be effective in the US, and for the last 2 decades, we've been working with colleagues in the US and internationally to adapt it for different cultures. So I am going to mute and I'm going to introduce.
So I'm so excited to join you all today. Good morning / afternoon / evening. And so I want to say I joined Dr. Bakitas' research team back in 2013. And my background is that I'm a critical care nurse, primarily in cardiovascular care. And I wanted to present a story today that is like an amalgamation. It's a combination of stories that both Dr. Bakitas and I have experienced over time. And so I'm going to talk a little bit about Mabel. So Mabel is a 78-year-old African-American woman who's been newly diagnosed with a brain tumor that was discovered by her local doctor after she had a seizure at home. She's very religious and she has many children, grandchildren, and great-grandchildren, but only her son lives nearby. And of course, after we've discovered this brain tumor, her local doctor referred her to the cancer center, which was over 50 kilometers away. And her family believes that she will receive better care there. And once she gets there and is seen by the doctors there, they inform her that her tumor is inoperable. And they recommended that she had palliative radiation and chemotherapy. And so with that, she goes home, returns home to pray and discuss this treatment plan with her family. So within a week of returning home, she develops a headache and begins to vomit. She, of course, goes to her local hospital because that's close by and easy to get to. And then she is airlifted to the cancer hospital that she had just been at. Mabel agrees to the palliative radiation therapy because she's told that it will make her feel better. Her family is, of course, unable to visit, one, because there's a lot of transportation issues. It's hard to get there. It takes a long time for travel, but also this is in the middle of the pandemic. So there's COVID-19 restrictions for visitation in the hospital. She soon becomes confused, hypotensive, and febrile. And during a lengthy resuscitation effort, her doctors attempt to contact her family to understand what Mabel's wishes for life-sustaining treatments are. And ultimately she dies alone. And so cases in 1999 for Dr. Bakitas and of course for me in the early 2000s, we encountered many of these cases like this, and it inspired Dr. Bakitas and some of her colleagues to consider how can they change the paradigm. And so I know Dr. Bakitas will return to Mabel's case in the end, and we'll revisit how we changed the paradigm, or how we hope we've been changing the paradigm. But first, I'm going to kind of move on and talk a little bit more about the model that came out of cases like Mabel that Dr. Bakitas and her colleagues, and now myself and some others are contributing to, which is Enable. And so all too often our rooms for our patients, like Mabel and so many others, look like this, where they're so full that you as the nurse or the family can barely fit in and find space to walk. And this is an example, a prime example of what so many of the rooms that I worked in looked like, where outside my orientation, I would have patients that I was trying to provide nursing care to. And in particular, there's one case that I think about a lot, which is a young man that I worked on heart transplant, and he had been transplanted. He was going through rejection, and he was back in with multiple organ failure. And so for my very first time as a nurse on my own, outside of orientation, I cared for this man, and I stayed at his bedside while he experienced cardiac arrest and he died. And as that unfolded, I remember very distinctly watching the family outside the doors and the grief that they were experiencing. And I thought, what if this could look different? How could this look different? But most importantly, how will we make this different? And this place where I was at did not have palliative care. And because of that, I started to seek out better ways to do things, which is how I ultimately ended up with Dr. Bakitas as first a PhD student and now a postdoc. And so we came to Enable. And I feel like I have a slide that maybe got skipped over, where we talked a little bit about what were the origins for early concurrent palliative care, which is Enable. And Enable stands for Educate, Nurture, Advise Before Life Ends. And it was developed by going back to patients and back to families and to clinicians, using focus groups, asking them a very simple question. And that question was, what do you wish you knew when you were first diagnosed that would have helped you better cope with your illness? And what they told us informed the basis for the intervention for Enable, its content and its components. And so I use Enable a lot. And one of the things that I always do when I talk to groups is I always want to say what patients get, what actually is Enable. And so this model is a version of what we got from those focus groups, from talking to patients and talking to family caregivers and clinicians. And so Enable was designed to be delivered by a coach to both patients and to caregivers in parallel, where we use behavioral activation, and we have several different components, and that includes a comprehensive palliative care assessment, or I always say a one-time in-person palliative care clinic visit. We have 6 guided sessions that are delivered by palliative care coaches that go through training. And they also have monthly follow-up calls. And so we have kind of an extended program of palliative care coaching that goes on. And more specifically, if you can go to the next slide, Dr. Bakitas. So when I say we have palliative care coaching that's done by nurse coaches, these sessions have very directed content. And of course, it maps on to what we consider comprehensive palliative care. and they build off of one another. And so that very first session, that enables session 1, the first thing we do is talking about what is their understanding of their illness. So on disease prognosis understanding, and understanding what is palliative care, because remembering back to what the slide that Dr. Bakitas showed, over 70% of the US population is unaware of what palliative care is. And so taking the time to introduce what is palliative care and what does palliative care bring to the table, and how they can support patients and family caregivers in that advanced illness trajectory. The importance of what the caregiver role is. So often, I as a nurse, and I'm sure Dr. Bakitas as an advanced practice nurse, saw family caregivers who are providing the day-to-day care for their loved ones not get support in the way that they need it. And it's a hard journey, and it's something that many people have not asked to do. Also in that first session, we do something that's called the COPE attitude. And it's so viewing illness with a different perspective, and kind of thinking about ways to cope with illness. And then the very last thing we do in that session is called problem solving support. So working through the issues, whether it's disease related or not, giving them a good framework to think about problems. The second session is on self-care and symptom management. And particularly as a heart failure nurse, this is something that's like a mainstay of what I think of good comprehensive palliative care is. And so this can include things like, what is self-care? What are different strategies and activities can you do, like healthy eating and exercising, or smoking cessation? How to identify symptoms and what to do once you identify those symptoms, including connecting you with your local nurse or your local physician, or when to call the specialty on the oncologist, or in my case the cardiologist. Also acknowledging that with a serious illness diagnosis, there's a chance that they'll feel depression and experience grief related to that diagnosis, and giving a space to acknowledge it and also address it is part of session 2. And then the last part of this session, we also talk about things like coping with loss. And loss can come in many different ways. It can be the loss of the life that you expected to have, but the things that you cannot do now related to some of the disease symptoms that you experience. I mean, and loss certainly could be thinking about, the fact that at some point, especially from that family caregiver's perspective, that your loved one, might have severe disability and might pass away. And so acknowledging that, addressing it, and giving them strategies to cope with it. And then our very last section in session 2 is speaking about spirituality and the role of spirituality within caring for those living with advanced illness. Our next one, session 3, is about communication and decision making. So we kind of give them all of these tools to deal with the serious illness, and now we want to arm them with one more tool for communication. And it's communication between the family and the patient, but it's also communication between the family, patient, and the clinician. And so with this session, we talk a lot about what are communication skills. How can you prepare for your visits? Because inevitably what we've heard from interviews and talking with patients and family caregivers, they get into the doctor's office and then all of a sudden, they can't remember all of the things that they've been struggling with for the last couple of weeks. They can't remember the questions. And then we speak from a clinician standpoint, we talk in ways that that make it hard for them to understand the information that we're saying. And so, I mean, one of the things I think about, of course, on heart failure is that, we'll use medication names that are really complicated, and instead of saying some sort of long diuretic, my patients often refer to it as their water pill, because it pulls off, in their words and thoughts, pulls off water from their body. And so how to prepare and for patients and their families to advocate, to say, I don't understand what you're saying. Can we say it in a different way? The other thing we do in session 3 is that we talk about how to provide a support network, identifying people in your families and in your communities that can support you as the patient and kind of coping with your serious illness. And different ways to ask for help, because I think that's a big step for so many of the patients and the families we deal with, is that being kind of at a place where they feel comfortable reaching out to others to say, I need help coping with this. Can you do this or this? We also in this session talk about medical decision making, and that includes things like using decision guides like the Ottawa Decision Guide, which is a very structured step-by-step guide about how to think about complex medical decisions. And again, because I'm a cardiovascular nurse, I think about things like going up for a heart transplant or having a ventricular assist device implanted. These are really big decisions, and having a systematic way to think about it can be really helpful for patients and their family caregivers, because it's more than just, as Dr. Bakitas has already introduced palliative care. It's about quality of life rather than just life-sustaining treatment. And so much of our medical model in the US has focused on sustaining life, but not really thinking about, well, what's that going to do to impact their quality of life as well. And so in this section, of course, during medical decision-making, we also talk about advanced care planning and about how you want to think about what are some decisions you might face down the road, and what if you were in a spot where you could not talk for yourself, what would you want? And so our next section, I'm going to kind of put them all together because they have very similar and they kind of build off of each other. So for sessions 4, 5, and 6, this is based off of what is called the Outlook intervention that was developed by Karen Steinhauser. And it has a couple of core elements. It has life review, thinking about forgiveness, people who you would like to seek forgiveness from or receive forgiveness from, and also legacy building. And so all of these elements come together to support the patient. And these are sessions that only the patient receives, supports the patient to understand their illness within the context of the sum of their total life. So that, in a very brief nutshell, is Enable. And then with that, I'll turn it back over to you, Dr. Bakitas.
Rachel, thanks for providing that comprehensive overview of what the Enable intervention has entailed. And I look forward to the audience if they have questions about specifics as we continue on. So as I mentioned, Enable was a idea that grew from the World Health Organization recommendation of doing something at the beginning of a new diagnosis of serious illness. And we started this work as a demonstration project in 1999, and we were funded by the foundation, the Robert Wood Johnson Foundation. Since that time, and this was a feasibility study to say, could we even do it? Would oncologists accept having concurrent palliative care when patients were newly diagnosed? And the answer was yes. We did find it was feasible. They loved it. The patients' families loved it. But one of the things we learned in the demonstration project was that in the terrain of New Hampshire and Vermont, where we did our first study, it's very mountainous, it's very snowy, and it's very rural. And so we had originally intended for our patients to get the Enable sessions in person and in a group. And what we found was that about half of them couldn't make it to come weekly for these sessions. And so we were committed to providing the information by telephone. And that's when we converted to meet the needs of the patients and families to do it primarily as a phone-based intervention. And so when we did our first randomized trial, which lasted from 2003 to 2009, we did it predominantly by phone after that one in-person consultation, comprehensive assessment. And what we found in this randomized trial, which is a very structured, rigorous way to look at palliative care using Enable versus what usually happens, usual care, was that patients' quality of life improved over the period of the trial. their mood improved, so depression and anxiety, their symptom intensity, and also they lived longer, which was a really big surprise that, that we found. The follow-up study called ENABLE-3 was done in 207 patients, and this time we added the intervention for caregivers. Early versus delayed was the method that we used to do the study, because ethically we couldn't withhold palliative care now that we knew that it was beneficial. And so based on conversations with patients after ENABLE-2 study was over, we realized that for some people, it wasn't really as relevant or as useful at the beginning. And so we did what's called a weight control or delayed design of the study. And we did the second, half of the patients got palliative care up front, just like we did with ENABLE-2, but half of the patients then got randomized to the intervention group. I mean, to get the intervention in a delayed fashion. What we found there was actually, again, startling, that patients actually lived longer, and that survival was improved by 15% in the group that got it early. There was no difference in our quality of life outcomes, except in our caregivers, mood and quality of life did improve. I do see that there's a hand raised and a person in the chat, which we're happy to take questions along the way if that is suitable to you all. So would you like me to pause and take the question, or would you want to wait till after?
Yes, dear professor, we have a participant, Sona. I asked her if she can type. I don't know, Sona. We are waiting for your feedback. Do you have any questions?
Well, I'll continue, and then if there's something in the chat, I can just address it along the way. One of the other important things that happened with the ENABLE-3 trial was that it was published in high impact journal, the Journal of the American Medical Association, and then the ENABLE-3 was published in the Journal of Clinical Oncology, which is the premier journal of medical oncology. And in 2016, after the trial was completed, they published in their annual report of clinical cancer advances that this trial was one of the most important advances in cancer care for that year. So we were very excited about that. Since that time, we have been funded to carry out an implementation trial, which is another way where you see, when you know a practice works, how can you implement it actually in practice? And so that study is ongoing now, and we're trying to disseminate this care across 40 cancer centers, cancer practices in the US. So I guess at the end of the day, in terms of cancer care, these various US professional and international organizations, the National Comprehensive Cancer Network, the Institute of Medicine, American Clinical Society, the Society of Clinical Oncologists, and a meta-analysis said, we recommend this, which is that picture of very similar to the picture that we showed that you and in Iran have, and not this, or that old concept where you wait till the very end of life and then you offer palliative care. And their specific recommendation was that patients with advanced cancer should receive dedicated palliative care services early in the disease course, concurrent with active treatment. So now that we've established that this type of care, palliative care, is important at the beginning of illness, I think it's safe to say that one size does not fit all. The way that we did it in the US, and we'll tell you a little bit about adaptations we've had to make when we've translated it to to heart failure populations and patients with COPD, patients with cystic fibrosis. Each time this is translated to a different disease or a different population, it's really got to start with cultural adaptation. And so I like to say, remind us that biases are the stories that we make up about people before we know who they are. And so we can't assume that one person with cancer in the US is like a person with heart failure in Iran. It's very different. I call this focusing on our cultural lens. This part of our palliative care assessment is really critical. And you can see here that focusing on culture, that some of the aspects of culture are visible, but those aspects are extremely limited. You see some of them here, the way the person dresses, or their language, or their food, or their religion. Of course, what we see is what the patients choose to show us when they come into our clinics. Sometimes we actually have gone into their homes, and certainly during the pandemic, there was a lot of ahas that our caregiver or that our healthcare providers had when they started doing telehealth and seeing people, excuse me, seeing people in their home environment. So it's really been enlightening for us. We saw patients' families, pets, and a lot more about their home setting. However, the most important part of culture is usually not visible. Below the surface, these less visible aspects are probably more important and more likely to explain how we should be with patients and their families. So this is what we bring to our work, and I call it the palliative care lens. So what you see here is our clinical practice guidelines for quality palliative care, which are now in the 4th edition. And these are used and available internationally. And one of the things that I want to point out is that the first edition of these guidelines was published in 2004, almost 18 years ago. And this guideline was the first roadmap we had about how to provide optimal palliative care outside of hospice. Back then, there was a singular focus on providing expert pain and symptom management, especially at the very end of life. However, while these guidelines were a boon to the field, we had much to learn about how to really make a difference in the lives of all persons with serious illness. So it was in that same year when the first version of the guidelines were published that we had just completed our palliative care demonstration project. And based on much evidence, however, what we've learned over those last 18 years is that what I have highlighted in red, which is now part of the guidelines that wasn't there before, are some of the key areas of assessment that are most important in our palliative care assessments. And that is social determinants of health, abbreviated as SDH, culture, and spirituality. And it's safe to say that these areas in the earlier guidelines, with their focus primarily on symptom management and end of life, were lacking. They weren't there. I actually did a word search because we were providing palliative care in rural settings, and many of the guidelines couldn't be carried out there. The word rural was never mentioned in the first 3 versions of the guidelines. And so now we've learned a lot about how social and cultural factors, caregiving support, spiritual concerns are key elements of what we should be assessing when we assess our patient in order to provide the best palliative care. So maybe you're skeptical and you're saying, well, why do you say that? Well, we do have data to support this, the importance of culture. Here's a framework that we use in the United States very often that considers the impact of these things called social determinants of health, which are the socioeconomic and physical factors in the environment. This slide shows that at least 50% of a person's health outcomes are attributable to factors that are not the clinical ones we pay attention to. And only the smallest portion, or about 20% of patients' outcomes, which is the care that we provide, which I actually venture to say it's disease-focused care, is where we're spending all of our time, but we're ignoring this 50% of what can be attributed. In the US, we have our zip codes, and we say that 50% can be traced back to where a person lives or their zip code. Our academic centers are very well equipped to understand disease down to the aberrant disordered genetic code. But even though their prognosis may be more accurately determined by investigating their zip code, our science has little experience or readily available technology to diagnose an individual patient's social determinants of health phenotype. And I think the comprehensive palliative care assessment that I mentioned is the closest thing I found to having what I call a person scanner. So if this social determinants of health is done correctly, assessment is done correctly, it can help us to identify some of the factors that are most impactful on our patients' outcomes. And this is where we need to be focusing our research efforts going forward if we want to make a dent in improving care. So let me illustrate this point a little further with some data. This is a study that was done by my colleagues in the cancer cooperative group that's called the Southwest Oncology Group. And or SWOG for short, is a national group that brings the best palliative care, newest investigation clinical trials across the country to cancer patients. They've been in existence for 35 years, so they've been doing this for a long time. And what this study did was look at the data from 55 clinical trials representing 41,000 patients with 24 different cancer histologies across all different cancer stages. The underlying premise of this study was that all of these 41,000 patients had been treated on very strict treatment protocols and were receiving the best available cancer treatment for their disease. They used this thing called the Area Deprivation Index to compare patients who lived in the most affluent areas, shown here in blue, and this is in the United States. So they looked at this thing called the Area Deprivation Index, and the most affluent areas shown in blue are here. And they compared patients on those trials who lived in the least affluent areas, which are shown in the yellow to orange colors. Sorry. And what they found was, well, first, just a second about the Area Deprivation Index. This is 17 indicators at the neighborhood level of socioeconomic status, education. There's 2 measures about employment, housing quality, and poverty. And so when they looked at all of this data, they found what's shown in this graph is that those living in the highest areas of deprivation had worse overall survival, worse progression-free survival, and worse cancer-specific survival. So that the magnitude of the difference between these two groups people who lived in the highest deprivation and the lowest deprivation areas was equal to what we call a treatment effect. So high area deprivation is associated with high risk of disease progression and death, and that the difference was equal to a treatment effect. Now, what that means is that the best available treatment being received the same way by people across the country cannot be overcome by having these low socioeconomic and social determinant of health or low area deprivation or low access to that 50% of those components that I mentioned on the earlier slide. And studies like this stress that future research should examine the etiology of this disparity. Was there less access to supportive care or post-protocol therapy? Was the chronic stress of poverty and structural racism and economic deprivation somehow altering immune or neuroendocrine responses and thus making the treatments less effective? So, all in all, you can see the importance of assessing the patient, them, their culture, their neighborhood, and all of these other areas, in addition to providing good palliative care. And the way that we'll do this is different for different populations and different cultures. We use this process called community-based participatory research, which means that when we go to adapt our interventions, we involve the community that's being studied as equal partners. We use their knowledge about the community to help us understand their health problems, and we get their input on research methods and results, showing the community that the benefits that they could achieve result from their participation in creating the intervention and doing the research. The CBPR process fully involves the community in all aspects. Members are respected as partners, and we recognize the unique strengths of each member. Some evidence to show you kind of how we did this process over the years is here. The booklet that accompanies our Enable intervention is called Charting Your Course. And this is the first version of the booklet that's shown here when we were doing our cancer work. That sailboat logo is to stand for navigating, how we were helping people navigate through the illness experience. The second picture here was when we translated Enable and the Charting Your Course to heart failure. So we pretty much used a similar logo, but stressing the cardiac nature. And then what we learned from our population when we moved to the rural South is that they were much more accepting of this type of care if it looked or was branded in the same way as their trusted healthcare institution. And so we changed our cover to reflect that people who looked like the people that we were now serving, because the northern US where this was developed was a fairly white, Western middle-class population, and the population where we are here in southern United States, in Alabama, was much more diverse. So you can see the evolution, and we did these changes with the input from our patients that were going to be undergoing this. When we stepped out a little bit and used Enable in one of our first projects out of the United States was in Honduras in South America. And this was in a clinic that was treating patients with cancer, which was very different from the clinic that we first started this care in. What we found when we did our cultural translation is that although the model was pretty acceptable to staff and patients, they really wanted much more content about symptoms and how treatments happened and how treatments were scheduled. And the nurses specifically needed workplace modifications to be able to bring this treatment to their patients. They wanted a dedicated nurse who knew how to do this care and had the time and space to do it in order to really optimize the intervention. I've worked with some colleagues from Turkey who came to the US for a couple of years, faculty from Hacettepe University in Ankara. And one of them, Dr. Imat Akyar, was a lead in trying to bring this care to a Turkish population. Here's a picture of, I visited Turkey, and there we are on the palliative care unit down at in the bottom frame. When she went back to her country and was trying to think about how to implement Enable, what she found was it wasn't enough to just translate the words about palliative care in the booklet, but really, again, to talk to the patients, to talk to their families, to say, how does this apply in a Turkish population? For them, caregiving, unlike in the United States, where we describe this concept of caregiver burden, caregiving wasn't perceived as a burden. And in her study, 84% of caregivers said they derived satisfaction with caregiving and talked about it as a natural thing, a peaceful thing, that was performed with affection and love, and that it was a sacred responsibility grounded in their familial obligations. This is my responsibility as his daughter, was one quote from one of the patients. They found caregiving to be a religious duty to God. And about the communication, where Rachel nicely described how one of our sessions focused on communication and decision-making, they found the level of communication that we were describing in the US and decision-making and participation, and speaking about death, that these things should not be discussed, that cancer was not often disclosed to the patient, the patients were not involved in decision-making, and discussing death was inappropriate and rude. And so you could see how our intervention really needed to change in order to be appropriate in a Turkish population. Similarly, my colleague, Dr. Grace Yang, was also interested in translating this to a Singapore population. We have a nice paper on it. You can see how they adapted their guide with input from patients. And, I'll just give you one example about how the way it was developed in the US was not culturally appropriate for them in Singapore. And so they made a lot of modifications based on input. Specifically, again, diagnosis disclosure was not a culturally appropriate approach. And the patient quoted, I'd rather not, or the family member actually said, I'd rather not tell them, the patient, the big C word, because that would be taking away hope of the chance for cure. And so how they did their adaptation was they assessed patients and caregivers' preference for disclosure of diagnosis and prognosis before they would approach this, and then checking if the family were willing to participate in Enable and to focus on the content that didn't require awareness of an advanced cancer stage or prognosis. And here I'm so excited and proud to show you the work that Marvin, Dr. Manoukian, and other professors are doing to start the process of translation of Enable to a Persian population. So more to come. And when you have questions about this, I'm not your expert. That would be my colleagues here. I'm going to ask Rachel now to talk about the adaptations that we've been doing of our palliative care model for cancer. For cancer family caregivers.
Yes. So so I'm speaking on behalf of a colleague. Dr. Bakitas was joined back around 2010 by a PhD student at the time, who's now an assistant professor, Dr. Nicholas Dion Odom. And his program of research has focused on how do we adapt the palliative care interventions for family caregivers, and particularly, moving from an area in the Northeast United States, which, like Dr. Bakitas was saying, geographically looks very different. It's mountainous and snowy, and also looks very different. It tends to be middle class and white family caregivers, to where we live right now, and in what we call the Deep South, which again, still a rural population, but a much more diverse population. And there's a lot of cultural differences between these two very distinct areas of the United States. And I find that a lot of our family caregivers, particularly those that are minority, our African-American family caregivers, much like the caregivers in Turkey, find caregiving to don't perceive it as much of a burden. So even within the state of Alabama, we have kind of distinct cultural experiences between groups. And so Dr. Dion Odom has focused on building this program of research, where he has started with formative evaluation. So very similar to that community-based participatory research, where he is working in partnership with family caregivers and with patients and clinicians to develop interventions that can help support family caregivers, and particularly those that are dealing with advanced cancer diagnoses. And so these, again, are just an example of a couple of the articles that he's done, where he's gone to these groups to have interviews and focus groups to see how they envision comprehensive palliative care would look. And it includes things like making sure that we do have a face-to-face connection in some form or fashion, making sure that the sessions are flexible, because one of the things that, as the caregiving needs of that patient increases, some of the time and commitment that family caregivers have decrease. And so we have to flex the palliative care to meet the other needs that they have. And sometimes that means that we, instead of checking in once a week, we're checking in far less, but doing it in different ways. We actually now do some texting, which is definitely something that I think back in 1999, we probably did not envision as a way to deliver palliative care. One of the other really interesting things that Dr. Dion Odom is doing is moving from kind of this research space where we are and where we're trying to figure out, models of palliative care and models of telehealth palliative care, to providing a very formalized caregiver support service within the health system in the United States. And so one of the good fun things about kind of working with different groups and groups in different countries, of course, how we fund care is different. And we have private insurance companies, and our health system looks very different from place to place as we're collaborating with different groups. And so one of the issues that we struggle here in the United States with is finding ways to bill from a clinician standpoint for the palliative care services that we provide, and particularly for family caregiver services. And so there's not a robust system yet. So we're still in the nascent beginning stages of figuring out how can health systems have routes of entry for caregiver support. And so one of Dr. Dion Odom's projects includes doing that and at UAB in Alabama, and providing services for those that are living with, providing care for those that have advanced cancer. So next slide, please. One of the other things that has come out of the work that we do with community-based participatory research, and also the interviews and focus groups that we work with, is this idea that from the clinician side, that we need to think of ways to create more sustainable and scalable models, because we, especially in the state of Alabama and in the southern US, we do not have enough specialty trained palliative care providers to adequately meet the need of all those that are living with serious illness. So beyond a cancer diagnosis, so for patients that are dealing with heart failure and COPD and ALS among other things, and the fact that we know that for our population, one of the things they really value is working with trusted partners. And so while we have conceptualized that first with that transition from the Guiding Your Course guidebook from the heart to actually having the UAB branding, one of the other ways that has come out from these partnerships and these discussions that we've had with patients and families and clinicians is that we are now turning to what we call lay navigators, to trusted community members to provide the beginning stages of comprehensive palliative care for our patients and family caregivers. So these are individuals who do not have health training. So they are people who are embedded in their community. They know their community well, and they provide a link for our patients and their families to the health system, but also to other community resources that again, they are aware of that I might not be aware of if I'm based out of Birmingham and they live in a town that is 50 kilometers away. And so one of the really neat things with a lot of our projects going forward is that we're utilizing this workforce to provide this primary palliative care. And they're really coming to the table and meeting the unmet needs of these patients and these family caregivers in a variety of different ways, whether it's through referrals, formalized referral process within the health system, but they're also providing intervention where they are addressing the emotional and education needs of those patients and their families. And it's flexible. I mean, again, we're meeting the people where they are, and we're listening to what patients and their family caregivers are saying that they need, and providing structured intervention to help with that. And of course, with that, one of the things they do is ongoing needs assessments. So with this in mind, one of the current projects that Dr. Dion has that utilizes lay navigators to deliver a palliative care intervention is called Project Cascade. And so this is a family caregiver-based intervention for those that whose loved one have been diagnosed with advanced cancer. And the idea behind this particular intervention is that we're going to try to help caregivers in providing effective decision support to patients. And so one of the things that Dr. Dion and I have also heard again through these interviews and focus groups is that caregivers don't go through formalized training on how to best support their loved one, and they want more information and they want guidance, and particularly when it comes to providing the right level of support at the right time, because sometimes it's a little too much and sometimes it's maybe not enough. And so Cascade came out of this idea, listening to caregivers, and we've kind of put this together where, again, it's navigator led. It is phone based right now only because of the pandemic, but we do have a component that is originally meant to be delivered in person. And it is, it's this particular design, it's a factorial trial. So we're testing out how much of the intervention needs to be delivered. And it, again, is structured. They have a guidebook that they follow alongside their navigator palliative care coach. And so one of the other projects is my project that uses lay navigation, and it's called Project Upholds. And I put these two pictures up here. One, because these are the two areas where I grew up. So I am not from the Northeast United States. So I grew up where I am now, where it is incredibly rural. And these are stretches of the highway outside of the two houses, the primary houses where I live. But it's also, it looks very much like what many of my patients and their family caregivers houses and areas that they live look like, where you can go stretches, kilometers and kilometers of road and not see a single soul other than maybe a cow or a goat in rural Alabama. And so with this in mind, I have gone and collaborated with many of our patients, family caregivers, and clinicians to ask about how can we adapt and optimize early palliative care for this population? And we know that there's a critical need regarding heart failure, particularly in this area where Dr. Bakitas and I live, because we have a really high proportion of under-resourced individuals who experience high heart failure related mortality and morbidity. But the palliative care science around heart failure and palliative care is still in the beginning stages. It's not nearly as robust as it is in cancer. And so while there have been some interventions that have been tested and demonstrate some effectiveness, they have not been widely translated into practice. And so now I'm hoping to optimize this intervention to make it more scalable. And again, using navigators, delivering intervention by telephone. And because it is looking to optimize, it's different combinations of the same elements of what I consider good comprehensive palliative care, which is, is education about symptom management and self-care, having discussions, helping with communication, and also advanced care planning. And so, like I said, all of the work that we've done since 1999 on to April of 2022, where we partner with patients and family caregivers in really developing interventions. And so I'm in the process of interviewing older adults that are living with heart failure. I'm interviewing heart failure clinicians and palliative care clinicians. And I'm also interviewing navigators, lay navigators, because they are not often found in the palliative care space, and even less so for palliative care for advanced heart failure. And so we have gotten a lot of feedback, which it will then be incorporated into the intervention. And some of that feedback is that navigators need to work in partnership with trained clinicians, whether that's a nurse or if that's a physician. They need to have that collaboration piece. The other thing that's been really interesting is that patients and their family caregivers have talked time and time again about the financial distress that they experience living with advanced heart failure. And again, this might be something that's unique to the US because of the way that we provide health care in the US and the co-pays that come along with having a serious chronic illness can be quite high. And some of these guideline therapies that we would give for heart failure are really quite expensive. And so one of these new ways that we can think about providing high quality palliative care would be, again, remembering the context of our patients and our family caregivers. And that context and some of those social determinants of health are that $500 you have to pay for that medication might mean that you don't have food for that month. And so, making sure that that's part of the assessment that we are providing. And then of course, we have a couple of other things, other feedback that includes about the importance of face-to-face contact. So many of our patients, particularly in the pandemic, have really struggled with loneliness. And loneliness assessment in palliative care is part of it because we know that that's connected to quality of life. And of course, that's the primary aim in palliative care. Again, meeting people where they are, whether it's where they are in the disease process or where they are with the environment that they live in, just being mindful of that. And of course, shorter sessions. Staying on the telephone is not everybody's favorite. So making sure that, again, being mindful of what people want. And so having these interviews have provided feedback into what an intervention that would look like for this population. And their comments and their thoughts are driving development of the intervention. So I've just highlighted in red a few of the things that have changed based off of partnering with patients and with family caregivers and clinicians and navigators in this process. And I think with that, Marie, I'm going to turn it back to you to cap off Mabel's story and say where we go from here.
So thanks, Rachel. It's really important that, and I think we've made the point that cultural tailoring, whether it's a different population or a different culture, is really critical. So I'd like to just go back to our patient Mabel that Rachel introduced. That really was, again, a compilation of patients and the issues that we see here, especially working in a rural and under-resourced environment. And I'm hoping that you can see how what we've learned and the innovations in palliative care could maybe rewrite Mabel's story. So I'm going to ask you to look into my crystal ball and see how her care might look different in an age of mature, evidence-based, culturally responsive, telehealth palliative care provided in a rural area. So you remember Mabel, she had a newly diagnosed brain tumor. It was inoperable, and her the cancer center doctor offered palliative radiation and chemo, and she went home to discuss this and pray about her decisions with her family. However, now, because of her distance from the cancer center, and she and her local son are enrolled in a telephonic palliative care program, something similar to Enable, perhaps. Mabel's nurse coach helps coordinate her care with her local doctor and community resources, and she learns about how her goals and values should be used to guide her treatment choices, and that her son also has a lay navigator available to support and coach him. She learns how to have conversations with her family about her wishes, and her coach helps her to complete an advance directive document that makes her son her healthcare proxy. She makes sure everybody in her family and her physicians know what her wishes are before anything untoward happens. At this point, Mabel opted for palliative treatments that she could get in her local community to control her symptoms, rather than at a far distant cancer center. Her nurse coach organizes a video consultation with the cancer center's palliative care specialist team because there isn't one available in her local community. Together, they come up with a proactive plan for home support and symptom management, including home emergency medications in the event of a potential problem, the common symptoms that you would expect with someone who has a brain tumor. She continues to participate in her valued church activities, and her congregation prays for her. They provide her with meals, help with chores as needed, and her family no longer believes she's going to get better care at the center that's 50 miles away. Mabel and her family have regular Skype calls with her local healthcare team to answer questions and to make sure that they're on the same page. They reminisce, they do life review and legacy work. One day, Mabel becomes confused and reports a headache and starts vomiting. Her family contacts the nurse coach, who activates the emergency care plan, which allows Mabel to stay in her home and get rapid symptom relief and home hospice. Her family gathers at her home, and as death nears, her family and her church members say their goodbyes. And at the end of this, you feel satisfied knowing that Mabel's wishes were known and they were followed. And during bereavement calls 3 and 6 months later, her family continues to thank you for the care and know that their mother is at peace. And they tell all their friends and family and congregation about the benefits of palliative care and hospice for their ill family members. I hope this is the vision that we can all expect from our efforts in trying to improve palliative care. So in conclusion, I'd like to end where we began. Let's stay committed to working together, joining hands across the globe to reduce suffering, leaving no one behind as we pursue equity and access to palliative care. And this is one of my favorite quotes from American anthropologist Margaret Mead. And we want to remember that even though we are a small group, we are growing and we can accomplish much. And the way that she said it was, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. So I'd like to end our presentation here and thank you very much for your attention. Rachel and I both thank you. And I'll stop sharing and we can take, we're happy to take any questions.
Thank you very much, dear Maria and dear Rachel, for your brilliant and informative presentation. I really enjoyed it. Dear participants, if you have any questions, please feel free to ask. You can type on chat box too. It seems that there is no question. Okay, dear Professor Bakitas, thank you very much. It seems that we have some common problems, common challenges, and common understanding also. You know, some of the factors that you mentioned is similar to our context. We have faced many challenges. For example, about the caregivers. Caregivers are one of our challenges in palliative care in terms of their emotional status, their lack of knowledge, and their lack of ability to provide appropriate care for the patient. And still, family members remain the main caregiver for palliative care patients. And the other factor that you have mentioned also is late referral of the patient for receiving palliative care. As you have mentioned, palliative care should be provided concurrent with the main treatment. And also we have faced with this problem. But palliative care in Iran is on the verge of a major transformation, and we keep growing, and we hope that we will have more improvements in the future. Okay, thank you very much. If there is no question, one message in chat box. Can see that culture is the important in palliative care. Muhammad Moin asked, dear Muhammad, may I ask you to explain your question or propose it in another way? Can see that culture, what do you mean by saying can see the culture? You mean the significance of culture in palliative care. I think he wants to know the significance of culture in the palliative care. Could you please talk about that, dear Professor?
Sure, I'm happy to. And I think that, you know, because palliative care deals with people who have serious illness, each of us, how we view illness, how we view quality of life, how we view end of life and death changes from one culture to another. A drastic example of this is when we were doing some consultation across the US. Our program goes often to different programs across the United States. We were in an area that was had a high population of indigenous population, American Indians from the Navajo tribe and the Navajo Nation, rather. And what their beliefs were that if a person died in their home, they would have to leave the home. But this was not, you know, and so whereas in many hospice and palliative care belief systems, the goal, and like our patient Mabel, that they prefer to die in their homes. But in this case, the culture was completely the opposite. And so trying to promote a system there, for example, where death at home was preferred was exactly the opposite of what their beliefs were. So we need to be able to make modifications in, what the common belief might be across cultures. And I agree, it is the most important thing. And I don't know if you or Arvin would like to comment on some things maybe that you're finding, in the Iranian culture that are standing out for you in terms of ways to make palliative care be more acceptable, in your culture.
Sure, Professor. Do you have my voice?
Yes.
For my thesis, I'm working in palliative care, and Dr. Bakitas is my advisor. She's my advisor for my thesis. One problem that I have in the sampling part was that when I was explaining to the patient that we are going to do a palliative care for you, and they really thought that, when you want to, as all of the audience here know, the palliative care in Persian is called Bakitas. And when you want, when I talked to them and I told them that we're going to give you some palliative care, they just thought that maybe they're in at the end of life. When just listening, there was the term tasking. They say, okay, so am I going to die soon or not? And I was explaining to them that no, it's not for the end of life care. This is the separate term that we're using. And I think in Iran, lots of people still don't have a correct definition about the palliative care, so we should work on it, I think.
Dear Professor, we have another question. What are the most important research priorities in the field of palliative care? Could you please tell us in your context?
Well, so I can certainly begin to answer that, and I would love kind of additional comments about that. And I think one of the things that was just highlighted, I think palliative care across the board and in all countries still really struggles with a what I call a public relations issue, where people are unaware of palliative care outside of the realm of hospice or end of life care. And because of that, that remains a research priority. How best to continue to kind of push forward with palliative care programs when there is such reluctance because of misunderstanding about what palliative care is. One of the other things that I think about is something that actually Dr. Bakitas highlighted. Well, two things. One, I think a lot of the research priorities is continuing to culturally adapt or to have culturally responsive models of palliative care. And that's going to, as palliative care expands, and I think about the fact that, from our US perspective, we think of it starting in England and then Ireland and kind of jumping over to Canada and then coming down into the US. So as palliative care continues to expand, a lot of the research work will continue to be, how do we have culturally responsive palliative care in other countries? The other thing I think we struggle with as a whole worldwide is, what are the metrics for palliative care in the research realm? What are these across the board, no matter which culture, no matter which country you're in? What are these ideal metrics that we're going to use to set the bar for what is good, comprehensive palliative care? And as Dr. Bakitas highlighted, thinking things about place of death is probably not it. And so I think moving forward from a worldwide research agenda, that's something that groups of us in all countries need to kind of reach a consensus for. So if somebody wants to take a stab at doing a very large Delphi project to try to get consensus for this, I would be all about that. But from my perspective, those are some of the main priorities going forward. And I don't know if others would like to join in and say some of the things, because of course, I have a heart for optimizing palliative care, but that's something that's very, you have to be in a place where you have a little bit more of a mature workforce and some interventions that have already been developed. So Dr. Bakitas or others, if you want to jump in and say your thoughts, I would love to hear that as well.
Thank you very much, dear Rachel. We have another comment from Somaye. My field is not palliative care, but I work on self-care of women with breast cancer in Iran and Italy. One of the things is give them the possibility to do independent things, even very small things. Do you think this can be seen in palliative care? What's your opinion?
Oh, I absolutely agree that my actual original training as a nurse was in rehabilitation. And so the field of rehabilitation tells us that the goal of care is to really maximize the individual's potential. And so self-care is a really key element of palliative care. And, you know, as I made the point at the beginning, palliative and supportive care, we really don't have a demarcation line of, well, it's only for people with curable disease, or it's only for people with incurable disease or terminal disease. So there's benefits that the strategies of palliative care offer for self-care to improve quality of life and symptom management and all of the other areas that are overlap, regardless of whether the person's going to survive their disease long-term or not. So I totally agree. Looks like Dr. Shavasari.
Yeah, Dr. Shahsavari is one of our scientific committee members, our Vice Dean for Educational Affairs. Thank you, dear Dr. Shahsavari. Please activate his microphone.
Do you hear me?
Yes, clearly. Yes, please.
Hello, everyone. I wanted to thank you to Maria and Rachel and RP, also my dear colleagues. And I have a question. I have a question that do you have, my question is about insurance and coverage of insurance for your services. Do you have any coverage for insurance or not?
I'll make a comment, but I think I'll let Rachel handle this one. It's quite variable. So the answer is it depends. So I actually have my background as a nurse practitioner, and I can bill as a nurse practitioner for palliative care services when I do an assessment and follow-up. It's a very low rate for palliative care compared to things like cardiac assessment, or cardiology or infectious disease, but still it is covered in most insurance plans as outpatient care. And if I do a consult on an inpatient, similarly, if they get a consult from an infectious disease or what have you. Now the trick is that a lot of times we bill by time, and the amount of time that it takes for us to do that complete assessment makes it very difficult. The other thing is that because we are an interdisciplinary team visit, I can bill as a nurse practitioner, the physician can bill as a physician. When we have people come in from counseling or massage therapy or the chaplain, and these are services that are just as important as my services as a medical provider, they can't bill for theirs. And so the reimbursement for palliative care is very low for compared to other services. But and it isn't necessarily covered by, in Medicare, it's covered under the hospice benefit and lots of regulations and restrictions there. So the answer is kind of. Rachel, do you want to say more?
That was pretty much what I was going to say. It is so highly variable. And so I am not a nurse practitioner or advanced practice nurse. So I was a bedside nurse, none of which is none of the services that I provide or have provided can be billed for. And the time thing, I think, is one of the thing that's most striking. So if we have a note that's detailed enough that you can then fit for the code and it can be billed, it in no way reflects the amount of time and effort that is given to that patient, and that's just patient. The family piece is a whole other thing. We do not have at this time really a great way to bill for services, and there are not robust programs to provide support for family caregivers through the private insurances or Medicaid or Medicare, which are public ones. And so as of right now, the onus for supporting those programs comes from most of the time the health services entity. So like UAB Hospital is basically providing the financial support for our caregiver support service line. And that's, you have to make the case. I mean, you have to have really compelling science for why this is important. And so it's a struggle, particularly for some of these interdisciplinary team members who are providing such high quality care, to not really have a way to be supported in that process.
And the program actually started, like many did, with philanthropy, so with donations. So we've had people who have benefited and have made donations. And I got the sense when I was looking through your websites and things that there's a similar kind of call for donations to help to develop the palliative care services in Iran too. So I would say that probably 50% or more of the funding for palliative care nationally comes from philanthropy.
Thank you very
Thank
much,
you so much
for your comprehensive explanation. We have another question, goes to Dr. Well. How important is palliative care at your university, and how much is taught in this field?
Okay, so I can definitely share the experience. So I was trained as a nurse, and I actually came into nursing not in our 4-year university degree. I have a degree in microbiology and then came into nursing. So I came in through a master's program here at UAB, and palliative care at that time, which was back in 2010, here was one day. It was 1 day part of our community nursing course that we had. And it was just kind of like, a comment. It was very, very much hospice focused. So it was focused on providing end of life care and only in adults too. Because while Dr. Bakitas and I have talked about from a very adult forward program of research, we also have colleagues who are doing pediatric palliative care as well. And certainly funding, finding billing for that and finding providers for that is a big struggle in our area where we are in the US. But it was a 1-day thing for me back in 2010. So not that long ago, 12 years ago. It is certainly something that at UAB, at our university, probably because of Dr. Bakitas and the growth of our palliative care program here, not only in research, but also in the clinical service side, it has become something that has been integrated throughout our bachelor's, our traditional 4-year degree and beyond in every single course. That is also driven by the credentialing board for nursing, for the bachelor's degree of nursing in the United States. It is considered part of the core competencies for nurses. And one of the things that I think we haven't highlighted perhaps enough, because the way that we were trying to present, we have kind of 2 buckets of palliative care in a way here. We have what we call primary palliative care and then what we call specialty palliative care. So the primary palliative care it's just the fundamentals of what is good quality palliative care that can be delivered by anybody that's providing healthcare. So I think, again, I was a bedside nurse. I ended up providing primary palliative care because I knew it was the right thing to do as a cardiac nurse. But it was not part of my official instruction. It is now part of the official instruction for all of our nurses as they come through the program. So I do expect down the line, as we have all these new graduates coming out and practicing, that we'll have kind of more incorporation of primary palliative care. We also have at UAB a palliative care track for our nurse practitioners and our advanced practice nurses. And so that's that is something that certainly was not always the case. We went through phases where we had it, and then as different faculty members left or interest waned a little bit, it maybe wasn't as active, and now we're kind of back on this upswing because, again, here at UAB with Dr. Bakitas coming in 2013, our program of research and our kind of has just ballooned. And so now we have several different groups that are part of what I like to call the Bakitas team. We all have our own program of research that is under this umbrella. And we now are one of the institutions that's known for palliative care in the Southeastern United States. So hopefully that answers your question, but it's the neat thing about how we do it is that it's not just one class you take. It's not just like a self-sustaining individual model. It is interspersed throughout their entire learning. And so that they understand that no matter what stage and what phase a person might be in their disease, these are core principles that we should be providing as nurses.
Thank you very much. It seems that there is no question and comment. At the end of this program, let me thank once more for your brilliant and fantastic presentation. Your contribution in this program means a lot to us, and I'd like to express my gratitude for your contribution. Also, I'd like to express my gratitude to the Praise to Raise team and also Directorate of International Affairs. Also, I should mention Youth Care Office and our students who have accompanied us during this program, especially our facilitator here, Arvin Mishahi, and also Faiza Samadi. Special thanks to them. And my last but not least thanks goes to our participants who have followed our program. I hope to see you again in our upcoming program. Before leaving the room, I'd like to ask all the participants to turn on their cameras to take a group photo. Thank you very much. Please turn on your camera, webcam.
Someone can as a question. Hand raised.
Hand raised. You have hand raised?
Yes.
I can't see. Faiza Samadi. Oh, please activate Samadi, who helped us a lot during this session. Thank you. Yeah, we have your voice.
Thank you so much. Well, first of all, hello to the professors and all the attendances. My question is that how do you see palliative care in 10 years ahead? Do you think that it might conquer many of the problems and complications that we have already and we're facing them, or many of the problems that that might be emerging in the next years? Do you think that palliative care will be empowered that much to confront these problems?
So I have great hope that all of the work that's being done nationally, internationally, the World Palliative and Hospice Association is working tirelessly to see that palliative care is as moving forward. So there are people, Dr. Stephen O'Connor, Dr. Kathleen Foley are working with, and I encourage you to, if you want to get aware of efforts that are happening in all of these countries to, it's free to access the Global Atlas of Palliative Care. And you can see over the last decade how much improvement and dissemination has happened. We've still got a long ways to go, but I definitely have that belief. I see things changing, again, in the US, in my area, and nationally. So I have great hope that we will continue as a world to care for each other, especially when there are times that we have great needs.
Yes, thank you so much.
Thank you.
Thank you very much, Professor. Once more, I'd like to turn on your camera to take a group photograph.
I also want to give a quick shout out to some of the folks that are on our team that have joined the program. Margaret Armstrong, I saw Jennifer Frank. So there's other members of our team who are here supporting us. I usually have, and I didn't put it in a picture at the end of all the folks in our lab, but our group from the clinical education and research areas at the University of Alabama at Birmingham. I would say that we have a group that's probably close to between 75 and 100 members who are doing all different aspects of this, from pediatric to geriatric and direct care. We have a unit, we have several clinics in across, and for veterans. So it's a huge team that I represent, that Rachel and I represent here today. So on behalf of all of them, I want to say we are grateful to have your partnership that will continue beyond just today's presentation.
Thank you for joining. And also we have Dr. Dimitrios from Greece with us. Thank you very much, dear Dr. Dimitrios, for joining us. It's a great honor for us. Thank you. Okay, I think the cameras are on, and don't forget to smile for photo. Okay, dear participants, once more, thank you very much for your participation. Hope to see you soon again. Have a nice day and goodbye. Bye.